Right, morning everyone. I think we're going to get started. So thank you for joining us this morning. There's probably still a couple of people who are going to join us, but I'll just start so long. And I hope those of you who are in Gauteng are staying safe and healthy. We actually decided to work from home last week already in our Joburg office, given all of the COVID cases that we're seeing in Gauteng at the moment. And for those of you who are interested, we also have a COVID dashboard on our website now. It's quite easy to find. If you go onto our main website, you can see where you can click there for the COVID dashboard. And we've got the results there by province, so quite interesting to see the results, how they're differing by province at the moment, with cases in Gauteng being really bad and actually exceeding the first wave and the second wave. But now this morning we have our second Foresight event for 2021. Some of you might be joining us for the first time, so just to give you some background, we started Foresight in 2016, so it's been running for a number of years now. And we usually have an in-person event in Joburg and in Cape Town, and we're really missing those and being able to see your faces and have discussions with you face to face. But since 2020, we've taken Foresight online. And Foresight is really just a space where we share interesting ideas and debate those with you. Sometimes some of our topics can be a bit broad, but also looking at topics that have direct applicability to the current challenges we're facing. So this year our theme is Reimagine, Rethink and Rebuild. Given the disruptions that we've seen because of COVID in the healthcare space, we're just taking some time to reflect on the past year or so and trying to imagine improved solutions so that we can rebuild our futures with more sustainability. So before we start today, I just want to give you a sense of some of our upcoming topics at our next Foresight, which will be at the end of July. We'll be looking at long COVID. We'll also be looking at activity levels during COVID, how they've changed. People working from home, change their exercise patterns, number of steps that you might be doing in a day. So we're going to look at what kind of impact that's had on health and wellness, and also looking at data security. But now first up today, we have Gary, who is an anaesthetist, and Gary's going to be talking about glucose control monitoring. And I think this is quite a pertinent topic at the moment, as schemes are actually looking at starting to fund these devices for their diabetics. But you'll see as Gary goes through his presentation that these devices are actually quite useful for anyone looking to monitor their body and see how different foods impact their body. So I'm going to hand over to Gary now to start with his presentation.
Good morning, everyone. Thanks for joining us from a cold and rainy Cape Town in the middle of a pandemic. So there's another pandemic that I want to talk about today. Just trying to clear my screen a little bit. Here we go. And there's my initial slide. So poor metabolic health. I've crossed out the is because we have a big one on at the moment, as we all know. I would say was the world's single biggest public health problem. Just reading or seeing the heat wave in North America at the moment, maybe it's the third problem because climate change certainly is for all of us going to be the biggest. Nevertheless, I think we can accept that this is a large public health problem. It does seem to be driven largely by diet, but current approaches really aren't working. So we're going to explore that a little bit and start with some numbers. So these are international numbers showing the extent of a global problem. So something like 1 in 11 adults around the world have diabetes. So that's homing in on 500 million people, and 1 in 2 are undiagnosed. And then where I'm going to go to with this presentation is a little bit upstream and what people call impaired glucose tolerance or pre-diabetes, which is roughly as many people, about 1 in 13. And the evidence is that the majority of these will progress over time from pre-diabetes or glucose intolerance to full-blown diabetes with all of the problems that that represents. So it's a global problem. It's an American problem, very much. And nearly 90% of Americans are considered metabolically unhealthy, which is quite extraordinary. And that metabolic unhealth or lack of health is defined by blood sugar and hemoglobin A1C, which is a long-term representation of your blood sugar value over time. And that's going to be my focus today. Blood pressure, waist circumference as a proxy for obesity in general, and some lipid values. So that's triglycerides and the so-called good form of cholesterol is one of the ways that that's measured. So metabolic lack of metabolic health is extremely common in the US. But lest you think this is an American problem, something like 3 in 4 people with diabetes live in low and middle income countries. And lest you think it's other countries in the low middle income world and not South Africa, here are some of our numbers, which are fairly recent from 2018. So 12.7% of adult South Africans are thought to have diabetes. As I've said already, about half are undiagnosed, and then nearly 10% have impaired glucose tolerance. That's pre-diabetes, and the attributable deaths from diabetes alone is something like 90,000 deaths a year. So here's some insight data. So that's from Insight's 3 or 4 million lives in its database, showing a dramatic increase in the prevalence of diabetes, increasing about 7% per year over the last 7 or 8 years. And back to the national data, roughly half of adult South Africans can be classified as overweight or obese. And so here's some of the companies involved in the diabetes space. You know, some big names, Pfizer, Lilly, Novo Nordisk, that make insulins and other diabetic medicines. And so this collectively represents a large part of the medical industrial complex, if I can use that term. So global health expenditure, 10% in the many hundreds of billions. So one can think actually of these companies as, in a way, vested with the current high incidence of diabetes, which is growing. Okay, so the term that we use to refer to this sort of triad of disease entities or health conditions of diabetes, high blood pressure, and obesity is metabolic syndrome. And metabolic syndrome is bad for us. It leads, I think, as I think most of us already understand, to high rates of cardiovascular disease, heart attack, and stroke. But interestingly enough, it's also strongly associated with conditions like dementia and certain forms of cancer. And now we're in the pandemic, and what I think we've seen right from the beginning is the intersection of metabolic syndrome with COVID-19 makes for a very unhappy set of outcomes. So these are some relative risk numbers. So mortality of diabetics with COVID-19 is at least twofold increased. And then you've got these other markers. So the disease tends to be more severe, to progress more, and the incidence of severe pneumonia with COVID-19 and diabetics is really high. So what is this all about? So I hope I've already convinced you that the numbers show diabetes is a big problem for public health globally, and what is the biology that underlies this? So I'm not going to dive into this very much. Just suffice to say that the biology is complex, and this is just a little bit of it captured in a really good review article in Nature a couple of years ago. And the key points here is that you've got not just one organ or organ system. You know, so I think you may recall from high school biology that insulin is made in the pancreas, but it's not the pancreas all by itself. It's the pancreas interacting with the gut and food and the microbiome of the gut, and I'll mention that again a little later. Interactions with the brain, with the liver, that's the big blob top middle, and muscles and adipose tissue in the block on the right. So it's a complex, integrated biology with all sorts of molecules passing back and forth. And any serious attempt to understand diabetes needs to look hard at this complex biology. But just to simplify it greatly, what we end up is insulin resistance. In other words, the insulin secreted by the pancreas is no longer as effective at the tissue level, despite the fact that and insulin levels go up. Over time, the function of the cells in the pancreas that produce insulin diminishes. The liver is affected by an infiltrate of fat into the liver, and this is known as non-alcoholic fatty liver disease. There's dysfunction and inflammation, actually, and breakdown of fatty tissue on the right. And down at the bottom, muscle becomes dysfunctional as well, and doesn't store ingested carbohydrate in the way it should. And the summary sentence out of this paper is that insulin resistance and pancreatic dysfunction occur simultaneously and continuously, increasing the risk of disease even before diabetes is diagnosed. So we can see it happening ahead of the development of full-blown diabetes, and perhaps there's something we can do. So back to the Americans, this fatty liver disease, I think, has had far too little attention. And astonishingly, about 30% of adults in the US have signs of non-alcoholic fatty liver disease, and as many as 13% of children. And shockingly, this is a disease that can progress all the way through to cirrhosis, to ultimately liver cancer. This is a common cause in the US now of reason for liver transplant, and ultimately has a mortality associated with it. Let's not forget the brain in the pathophysiology of diabetes and pre-diabetes, not only on a molecular level, but obviously the psychobiology of food. And I think we are probably all eating a little too much, or eating differently in the pandemic for comfort because of stress, sadness, boredom, and socialization may contribute to eating habits in quite a significant way. So let's not forget the brain in all of this. This is my sort of summary of the biology or pathophysiology of diabetes. It really does seem to have to do with overnutrition, which can be in the form of simply excess calories, but carbohydrate excess seems to play an enormous role. And there are both individual factors and environmental factors involved in all of this, which ultimately lead to insulin resistance at a tissue level, high levels of circulating insulin, and ultimately high levels of blood sugar. And the medical term for that is hyperglycemia. But it's not only about individuals, it's about the environment. So a huge contributor to all of this have been nutritional guidelines, and that's the food pyramid, which was published by the USDA, that's the United States Department of Agriculture, actually. So think about the sort of systemic implications of that. American farmers producing large amounts of grain and soy and so on, and that forming the recommendation for the base of the food pyramid. Climate change I referred to again, so we should be thinking about how we grow food and the implications for global climate. In large parts of the world, and having lived in the United States, I can attest to the fact that even in big cities in the US, many of them are food deserts, and supermarkets shelves are occupied with products that are not good for you, not healthy by any stretch of the imagination. And then finally, social and cultural factors play a big part in how we eat and what we eat. But all of this is leading, I think, to a large amount of confusion for all of us about what a healthy diet is. So I'm going to try and give you some sort of pointers without becoming a diet guru. So we face a situation where people advocate low carbs or moderate carbs, healthy carbs, high fat, low fat, protein up and down, eat less. Veganism is becoming more popular. Carnivores, paleo, banting. So I think it's a confused situation for both the rich, quote unquote, and poor people in South Africa, who unfortunately their base diet is often revolves around products like Coca-Cola and white bread and chips. So do the answers lie in nutritional science or nutritional epidemiology? Unfortunately, I think we've been led astray quite a bit. And this is a result, I think, of poor trial design, clinical trial design. A lot of it depends on self-reporting of dietary intake, which can be extremely inaccurate. Health outcomes may be unknown in the long term, and one really wants to see what the health outcomes are of a diet, not 6 weeks from now, but 6 years later. And if you read nutritional studies, every nutrient is associated with almost any outcome. Opinions can be fanatical, results implausible. So if you eat a handful of nuts 3 times a week, you'll have a 39% reduction in total mortality. Seems a little implausible. Some more of the controversies around saturated fat. And I think this is a quote from a meta-analysis in 2017. I think there's increasing acceptance that there's no significant evidence for effects of saturated fat consumption on heart or total mortality. That means that foods like dark chocolate, unprocessed meat, and whole fat dairy probably aren't sort of sinister foods, which is how we might have seen them 10, 20 years ago, based on dietary guidelines. Fiber is sometimes controversial. We seem to need a certain amount of fiber in our diet. But it's really not all about macronutrients and carbs versus fat versus protein. Meal composition at any particular meal turns out to be important, and the degree to which food is processed as opposed to being sort of natural is really important. So where does diabetes and glucose control come in? So I think these are really important graphs where you can see that a fasting glucose goes up. So when you have your glucose measured, it should be first thing in the morning after an overnight fast. And as your fasting glucose goes up, your level of risk for stroke, for heart disease, and cardiovascular death definitely does go up. And there's some normal values top left there for fasting glucose and pre-diabetes. And then the A1C, which is that measure of long-term glucose control over weeks below 5.7. And as you become glucose intolerant, those set of values shift upwards. So quite possibly, the ability to measure glucose continuously is a game changer in all of this. So these are 2 devices now on the market in South Africa, one by Abbott and the other by Dexcom. I'm not advocating for either of them. It's a simple procedure to insert the glucose sensor, which is a little sticky patch with a very tiny needle that goes through your skin into subcutaneous tissue. You don't notice it while you wear it. You can shower and bathe in it. And it's, as you can see, it's the size in relation to a penny. It's quite a small device. And along with this, you need a nutritional diary. And these are 2 examples of many available. Apps that help you capture what you're actually eating. And you need to do that on a regular basis to try to understand the contribution of your nutrition to your glucose. And then activity devices such as the Fitbit, Apple, or Garmin. So what the evidence from studies of CGM, continuous glucose monitoring, is showing is similar to what I'm showing you here. So participants, these are people without diabetes, get into the pre-diabetic range very commonly. So 73% of participants in the study were in that pre-diabetic range for almost an hour a day, in some cases. And about 5% of participants had blood sugar in the diabetic range, and quite a lot were in what is considered low blood sugar range, below 3.9. Here's another important study published in the journal Cell 5 or 6 years ago from Israel. 800 patients given both a combination of dietary challenges and what they chose to eat. And the really surprising and interesting finding here was an inter-individual variation in response to the same food. So participant 445 in this graph ate a banana and his blood sugar spiked, and with a cookie, very little change. And participant 644 had the opposite effect. So spiked with the cookie and flat with the banana. And that kind of inter-individual variation was really, really in this study. And what they found is that the majority of the variation of this kind was driven by the gut microbiome. And although it's not in the study specifically, some of it is due to your own genetics, your DNA. A third interesting study out of California made up this term called the glucotype, showing that across individuals, again, without diabetes, you saw people with a low variability blood sugar, moderate, and severe, and they were able to classify these on the basis of a mathematical process. And you could be in periods of low, moderate, or severe variability, shown bottom left in the graph over time. And the key finding was that the healthiest subjects showed the lowest variability in their blood sugar. Healthiest subjects, lowest variability. Okay, so dietary guidelines, as I've already shown you, were based very heavily on carbohydrates at the base. And that contrasts with traditional diets of hunter-gatherers, much, much lower component of carbohydrates. And a sort of modern American breakfast of cornflakes and milk, you know, that processed carbohydrate will put 80% of people into the pre-diabetic range and 23% into diabetic levels of blood sugar. If you have cornflakes and milk alone, that's from a particular study. So putting this all together, what is optimal, and what time should you spend in a particular blood sugar range? What should your blood sugar be on average, and how much variability should you have? So this is my own continuous glucose monitoring strip of 2 weeks. So assembled and combined with my nutritional intake over that time period. So the bars below the purple are the meals that I had, and the composition of those meals in terms of carbohydrate, protein, and fat. And you can see my 2 big spikes were one of my favorite meals, sweet and sour chickpeas. So clearly there was emphasis on the sweet in that meal, and I was kind of unaware of that. And then in the middle, I did an oral glucose tolerance test, which is actually a formal way of diagnosing diabetes, where you take a big load of glucose by mouth and you measure the blood sugar at 2 hours. So wearing a CGM enables you to do a fairly formal look at whether you may be diabetic or pre-diabetic. Here's a second CGM output. And this is actually, I hope I have Barry's permission to reveal that it's him. And week 1 in blue was, I'm calling it quite politely a liberal diet. I'm not quite sure what he's been eating. And he then ate in a bit more disciplined, or I called it a modified diet, on week 2. And you can see a dramatic reduction in the variability of blood sugar in week 2 compared to week 1. So what do we do with all of this? So the things to look at are clearly, what you're eating, and perhaps specific food challenges to see what happens. How we eat, mindful eating, meals versus snacks. When we eat, intermittent fasting is becoming popular, and timing of a meal can be really important, whether you eat your dinner early or late. And these are all potentially adjustable factors to keep your blood sugar in a healthy range. And as you do so, observe your blood sugar and how it relates to cravings, hunger and fullness, to your sleep patterns, to exercise and stress, to your general energy and well-being, to mental clarity, levels of light exposure, and if you have them, to menstrual cycles. So where I think this helps, this whole CGM approach to things, is firstly in risk assessment. and actually potentially diagnosing whether you have a pre-diabetic profile. And this is an extremely motivational set of data when you see what actually happens to your blood sugar in relation to eating. And I think the aim really is happy and healthy eating as a composite, without dogma, guided by your own biology, by your own personal preferences, and here with data. So just back to diabetes for a second. I think really interesting data is coming out to show that a ketogenic diet, that's a really low carbohydrate diet, and also a low calorie diet, heavily calorie restricted diet, can actually lead to remission of diabetes, which is rather astonishing. So around half of patients in 2 or 3 recent studies have been able to go off diabetes drugs completely with a purely dietary approach. So we can think of food as medicine. So I think we're going to see a lot more about food as medicine. And the bottom line with both the ketogenic diet and the low-calorie diet may be around weight loss. That's around 7 to 10%, leading people to much better metabolic health. And again, putting this all together, some people like to talk about health span. So that's not just lifespan, but healthy, long life, with happy eating, as I've said, at a comfortable weight, together with enjoyable activity, sufficient sleep, and social activity. And so within that idea of health span is, I think, metabolic health as a primary goal. So with a glucosome, a term that I've just made up, that's composed of A1C, your glucose range variability, and fasting insulin. We can look at your liver, we can and should look at your lipids and at your blood vessels and their health. And to do so, a basic panel, look at your genetic risk and do this tracking with CGM. I call this VIDA, not VIDA Cafe, but visualization of dietary effect. And there are a bunch of advanced tests that one can throw into the mix there. And this is my final slide, Zelda. To summarize again, I would say we should agree at this point that poor metabolic health is a huge public health challenge, now exacerbated by COVID-19 and driven largely by diet, but defying simple approaches up to now. And I think the solution sits with some of these factors, and I hope you'll agree, risk adjusted based on individual profiles, preference driven, because we want to eat healthy but still have a healthy life and enjoy eating. Requires feedback for behavioral change, and a CGM will help you with that. Has to be integrated into the healthcare system. Environmental modification so that healthy food is available and affordable is important, and possibly some incentives to activate people. And that's my final slide. I don't know if we're going to do any discussion or just flip to the next speaker. And thanks for your attention.
Thanks, Gary. Yes, we're just going to go to the next presentation. I also just want to remind everyone, if you have questions, you can post them in the Q&A chat, and we'll also have a Q&A session after all of the presentations. So after all of the presentations, if you want to ask your question live, we can do that as well. But if you just want to type it out, you can post it in the Q&A chat. So now we're going to move on to Poonam's presentation. Poonam is an actuary in the Cape Town office, and she's going to be talking about alternative reimbursement models.
Thanks, Griselda. So my topic today is less clinical than Gary's one. So I'm going to be talking about rethinking alternative reimbursement models, and mainly about how we rethink about entering into these models or contracts. So much has been said about the misaligned incentives in our predominantly fee-for-service environment, and we all understand the importance of ARMs in correcting this. By aligning the financial incentives, providers no longer have to depend on service volumes for revenue. Instead, they can prioritize high-quality, cost-effective care to improve patient outcomes. But this presentation is not about the advantages of ARMs. We all know this, so why am I speaking to you about this? So while this is not an academic talk, it's rather to share learnings from the many different ARM contracts that we've worked on. And these have been across the entire continuum of care, from GPs to hospitals and ancillary services in between. So what are our clients saying about these? So the feedback we get is that clients don't understand the contracts they enter into. They're not empowered to have the right conversations because they don't have the right information at their disposal. Some of them are not aware of the risk management options available to them because they don't understand the risks that they're taking on. And once they enter into these risk management contracts, they're not aware of the small changes in model parameters. They're not aware of the impact that those can have on their risk exposure. So this has created a lot of mistrust in the industry around ARMs. So I'd like to start by speaking about the distinction between risk transfer and risk sharing arrangements. So risk transfer means that the funder transfers risk over to the provider to manage. If we use a DRG-based fixed fee as an example, the funder is transferring over to the hospital group the risk of length of stay or level of care being higher than expected. So the hospital group will be interested in managing length of stay and managing patient outcomes to avoid complications. This is to make sure that their cost of delivering care stays within what is being paid under the ARM. So if the hospital improves their patient management such that length of stay or level of care is lower than that priced in the ARM, the hospital enjoys the savings achieved through this. The funder would obviously monitor length of stay to make sure patients aren't being discharged too early, but they're not required to actively manage length of stay since this risk has been transferred over to the provider. Under a risk-sharing arrangement, though, if savings were to occur, some of this would be shared back with the funder. So both the funder and the provider have a vested interest in the length of stay being lower than expected. The extent of the risk sharing is a function of the negotiation and how strong each party is. So generally, risk sharing contracts are set up such that the provider also shares in losses due to higher than expected claims. And of course, it goes without saying that these comparisons of actual versus expected should be risk adjusted. We have an arsenal of risk adjustment tools available to us at Insight, and the most common one used for in-hospital risk adjustment is our Insight DRG. For out-of-hospital costs, we've developed something called the Insight Episode Grouper, and we have a host of other tools and techniques that we can use for risk adjustment. So I think it's important to remember that risk-sharing contracts can occur in a fee-for-service environment, and many of the volume-based discount arrangements started up in this way. While these are easier to implement from an administrative perspective, because your reimbursement structure isn't changing, the disadvantage is that incentives are still somewhat misaligned. So another point to note is that risk-sharing arrangements don't only apply to medical schemes and healthcare provider groups. There exist risk-sharing contracts between healthcare system payers like the NHS and drug and device manufacturers in the context of value-based healthcare. So since we're on the topic of risks, there are two risks that I think don't get enough attention. And the first one is pricing risk. So we're used to thinking about utilization, severity, or demographic risks, but we should also consider pricing risk. So pricing risk is the risk that your expected price or utilization levels or any other assumption is wrong, or they just don't pan out as expected under real world conditions. So this is always a risk when designing a new reimbursement model with data that is not a perfect match. The estimates we derive are best estimates, which means that there's an equal chance that the actual result will be above or below the estimate. On the other hand, we have stochastic risk, which is represented by random variation in claims experience. While most of the variation in claims can be explained by certain risk factors such as demographics or case mix, or any of the other assumptions you saw on the previous slide, there remains an unexplained element, which can only be described by a random process. And the size of this variation depends in part on the size of the population being managed. The larger the population size, the lower the variation. ARMs involve taking on some stochastic risk, which can be directly quantified through the use of techniques such as Monte Carlo simulations. So how can these modeling techniques add more value to you? Well, they help answer questions that you should be thinking about. So the question we're used to being asked is, what is the best estimate of my future performance? And we can answer this quite easily. If I use a simplistic example, we start off by looking at past experience, then make certain assumptions about how this experience will change, and then set an expectation for the future experience. So what this simplistic example represents is a point estimate projection. So you only see one value here. We can enhance this through sensitivity testing by changing one assumption at a time to show what the impact on the projection is. And we can also run scenario testing to show what the impact of changing more than one assumption at a time is. But is this enough to make an informed decision? What questions should we be asking to be making a more informed decision? So I've put together a few important questions here. While clients don't always ask these questions, I think it's important to know the answer to what is the range of possible outcomes? What is the risk of loss? And what is the maximum amount at risk? So how much money are you putting on the table? What is the likelihood of achieving savings? And this is for when you're implementing new interventions. And how can altering the ARM impact the random variation of results? And we can directly quantify the risk to answer these questions. And I'll show you a few examples later. The reason we can add value to these analyses is because of the amount of data that Insight has available. Right now, I'm going to go through a few elements to consider when thinking about how ARMs should be set, and this will affect the answers to the questions shown here. So this is by no means an exhaustive list, but the first thing to think about is the target or benchmark. So this is what you'll be compared against. Or consider how your ARM fee is actually determined. It's important to understand how this is set and what methods are being used. Is it simply past experience with some risk adjustment? Is it based on a GLM? Or is it based on a more complex machine learning model? Different methods are appropriate for different ARMs. It's also important to understand whether you're taking on direct risk on direct costs only or indirect costs as well. Another tricky conversation to have with funders is there a premium if you're taking on risk? Providers usually don't have reserves or balance sheets to back up taking risk. So should some of the reserve building margin sitting with the schemes be transferred over to the providers in the form of a risk premium? This is because the funders are now exposed to less risk since they're transferring this over to the providers. So thinking through these elements will help understand how the change in the benchmark or target affects the likelihood of success. So it's up to the risk taker to define what success means to them. If success means an increase in revenue, then how much of an increase in the ARM means that it was success? Is it 1%? Is it 2%? Or is it 10%? Or perhaps the ARM is set up such that success means an improvement in the quality of care for patients. So the second thing to think about is risk adjustment. How will this play out? What factors are being used? Is it just age, gender, and chronic status? Or are there more factors that could better explain the risk? What methods and what tools are being used? For funders, it's important to understand what factors are manipulable by the provider. For example, if we paid a risk-adjusted capitation fee for diabetics that was higher than that for cardiac patients, will that result in more diabetic chronic registrations? So there's a trade-off here between the accuracy and the reliability of the factors being used. So thinking through this will help the risk taker understand how much risk adjustment will protect them from demographic risk. And if health status cannot be correctly assessed, how does this affect the risk that they take on? Another thing to think about is outliers. So how do we identify these, and how are patients or claims treated outside of the ARM? How are your trim points being set? You also don't want there to be so many carve-outs such that the ARM can't function properly. So thinking through this will help determine the overall impact high-cost claimant exclusions can have on the variation in your results. Another thing to think about is the inclusion of a risk corridor, and this is mainly for risk-sharing contracts. So what is the purpose of this? It's to protect you from losses. So generally, this is a two-sided arrangement, so the funder will expect to share in savings achieved as well. So thinking about this can help answer how much can a risk corridor protect me from incurring a loss, or reduce the likelihood of achieving savings for the risk taker. Another thing to think about is in capitation fee models, in the absence of formal GP nomination, how will patient allocation work? What is the hierarchy of rules for the allocation? And is there any bias in them? For example, in ARMs where GPs and specialists are involved, if benefit rules aren't changed to enforce things like GP referral, and the patient can visit the specialist whenever they want, then is the patient allocated to the provider they saw most recently, or is it GP first and then specialist? So the patient pool allocated to the provider will affect the risk-adjusted fee that the provider receives. So it's important to know how this allocation happens. Another thing to think about is savings, and this is savings expected due to any interventions being implemented. So how do you quantify this before interventions have been implemented? Sometimes you can use the experience from other plans where it's already been implemented, but sometimes these are brand new interventions. So how do we quantify these and take it into account? Is the saving baked into the ARM fee from the beginning, or is it accounted for through a risk-sharing contract that sits above the ARM, or a fee-for-service arrangement for that matter? Another thing to think about is in value-based care models, a proportion of the provider's fee is based on achieving good outcomes. So how do we define these good outcomes? And how do we measure these? Good can mean different things depending on the ARM. Can you directly measure the outcome, or are you relying on proxies for measurement? Regular monitoring is key here for tracking performance against expected outcomes. And the most important one, which I kept for last, is defining your risk-sharing formula at the outset is extremely important. The new model must specify all relevant parameters and methods in a technical specification, and this can accompany your contract, perhaps in the form of an appendix to the contract you sign. It's important to do this because small changes in the parameters can have a big impact on the risk taker's risk exposure. And having these conversations retrospectively can be very difficult. So I'd like to take you through a few examples, real-life examples of measuring stochastic risk. In the first one here, we looked at the effect of altering the ARM. So what we looked at here was 6 different ARM structures covering the same benefit categories, and we compared what the provider would have received under the ARM to the cost of delivery of care. And this was to determine whether the provider made a profit or a loss. We ran 10,000 simulations of this for a particular population size to get what the distribution looked like, so we could determine the probabilities associated with each of the simulated outcomes. So if we think about our original questions, what is the range of possible outcomes? We can see we can answer that question with this graph. If we think about the other question, what is the risk of loss? So if I was interested in what is the risk of loss being greater than 5%, sorry, let me just get my laser pointer here. So if I was interested in what is the risk being greater than 5%, I could determine that from this graph as well. If we think about likelihood of savings, I look at the other side of the graph, the right-hand side. And how can altering the ARM impact the random variation of results? We can see here that ARM1 has more variable results than the rest of the ARMs considered in this example. So if we look at the next example, this was the effect of an individual stop loss on an ARM arrangement. So an individual stop loss protects the risk taker against large claims from an individual patient. Basically, it's a way of carving out outliers. The way this would work in practice is that all claims for a patient above a predefined threshold would fall outside of the ARM. And it may be that these claims revert to fee-for-service or some other arrangement. But you can see the clear shift towards the right of the graph because high-cost claimants have been excluded. Another example here, we looked at the same ARM, but we varied the population size to show the impact on the variation in results. So if you're a provider taking risk on a population size of 1,000 members, although your sum at risk is smaller, the variation in your results is a lot higher than if you were taking risk on a population size of 10,000 members. So in summary, successful ARMs require good risk management, which requires you to understand the risks that you're taking on. So an important first step is understanding the key drivers or levers of that risk. The second thing is efficient delivery of care, and this is to translate into savings that you'd like to achieve under the ARM. And I cannot stress this one strongly enough, but entering into the right ARM contract, and this will be based on making informed decisions using the analyses we can help you with. What we want you to have here is the right design for the right contract structure and to ensure that each party holds appropriate risk. And then to measure performance regularly, which we can also help you with. This reminds me of a quote by an American businessman, I think. If you can't measure something, you can't manage it. And if you can't manage or control it, you can't improve it. So I hope the framework I provided today is useful, and we look forward to helping you with structuring your ARMs in the future. Thank you very much.
Thank you, Poonam. So next we have 4Rs. 4Rs is a company from the UK, and we're actually looking at doing a theatre benchmarking exercise with 4Rs in the UK, but they're going to speak about some of their experience in terms of what they've seen on elective procedures through the COVID pandemic. And I think what we've seen through COVID is that it's quite useful with other countries being in different trajectories compared to South Africa, to see how they've been handling COVID, as there's some useful learnings there that we can apply to South Africa. So I'm going to hand over to Henry to introduce himself more formally. Thanks.
Zelda, thank you. Just trying to start video. There we go. Hello to everyone. Sorry, my name's Henry. I'm on this call with a colleague of mine called Dan Boyd. So yes, as Zelda referred to, we've founded a company about 7 years ago called 4Eyes Insight. And what does 4Eyes do? We help organizations, we help healthcare organizations to, I guess, safely scale their activity in key points of the elective pathway. And we try and do that in a way that's safe, that's cost effective, and that's to the benefit of patients and hopefully the workforce as well, delivering it. So we cover a lot of areas on the elective pathway, and today we're going to be talking mainly about operating theatres and the operating theatre domain. But as you can see from that slide, we cover a lot of other areas as well, but we won't go into that right now. I think it's key to point out the methodology. We developed a methodology for theatres to objectively look at them. I think, referring back to the previous slide, if you can't measure something, you can't improve it. And so our challenge was very much to try and create a clinically credible methodology for assessing whether theatres are being run well or not. And so my co-founder, Brown Wells, who apologizes for not being able to be here, he used to run some of the big theatre operations in the UK. He was a theatre nurse by background. Myself, I used to be a medic, and since leaving medicine, being very heavily involved in data and the use of data to drive clinical improvements. And our methodology has now been used. It has now been adopted by the NHS. It's been used in over 120 of the organisations in the NHS. And so what we're going to show you here is it's the findings based on, it's the high level findings based on a data sample of 19 healthcare organisations. And just to put that in perspective, that's about 35, 38 hospitals and about 500 operating rooms. Sorry, we use the term theatres and operating rooms interchangeably. And it's data collected over the last 2 years. It's not an academic paper or anything like that, okay, just so, but it's a very data-driven approach. And what we're going to, what we're probably going to say is probably not going to come as a surprise to you, but it is, I can't reiterate enough, it's very data-driven and evidence-driven. We are also only going to be showing you a subset of what we have. So we're going to look at the headline figures for theatre performance over the last year and a half. I could talk to the cows come home on other stuff. I'll probably bore you senseless on waiting lists, additions to waiting lists, referrals to the pathway, on the day cancellations, length of stay, and so on. We're not going to touch all of that. But so yeah, we're only showing the headline figures. And like I said, if people want to go into more detail, happy to have that conversation with them. But on that note, I will hand you over to Dan.
Hello, good morning all. Just as Henry was touching upon earlier, to give you a scale of the sort of values that we're looking at, we have analysed, and we were asked to analyse one of the UK's regions. In terms of the NHS's structure, it's split into it's managed by the different nations within the UK, and within England, which is obviously the largest area, it's split into 7 regions. What we're looking at is one of those regions, the data set for one of those areas. And in terms of population of the UK, it represents about 15% of the population. As Henry said, you're looking at about 500 operating theatres, and this data set relates to that. Henry picked up on it. Poonam couldn't have done a better introduction for us. What we are in terms of, what we try to bring to the NHS and what the NHS uses us for is very much about the measurement of key metrics in theatres, using those metrics to generate improvements and to really give organisations a feel for what's going on in terms of numbers. What we're focusing on here is the elective cases. So it's not emergency lists, it's just elective care during the pandemic. And of course, it's a statement of the obvious, but just to get a feel of, in terms of the analysis that we were asked to do. So we were asked to do, in one of the regions, to look at the 4 months prior to the pandemic compared to the same period a year on. So what you can see in terms of the data, we're looking at the number of operating lists, the number of cases that were performed on those lists, the average case per list, and then the additional case capacity. So the way we measure the performance, the efficiency performance of the list is looking at, well, okay, this is what you did do, but how much more could you have done? And just to give it clinical credibility, that's not taken as an average figure across all surgeons. It's built on a surgeon by surgeon basis. So each individual surgeon is judged against themselves, and then all of that data is collated. As you can see here, so the 4-month period prior to the pandemic, and this is a representative average, monthly average that you'll see in a moment, but the UK in this region, they ran 20,431 lists. For the same period a year on, this was nearly cut in half. In terms of the cases that went through operating theatres, and this is elective cases only, for the 4-month period, in this one region, it was nearly 75,000 cases. Again, a year on, drastically dropped. And just to be clear, in this second period, it includes 2 months of a national lockdown. So you can see what's driving these low figures in terms of elective care. What the third row shows is that even for the lists that did run, previously, the average throughput, the average cases per list, which is the ACPL, was running at 2.7, and it dropped to 2.4, which is an 11% drop. And then we can see if the, even at the normal rate, for this particular data set on this slide, even in the pre-COVID period, there was the capacity on the lists, unused capacity, to do 26% extra in terms of what could have been, additional throughput for the list that ran, noting that there were far fewer lists, but even those that did run, this additional capacity for this data set jumped up to 36%. And what you can see here is what we sought to do is just look at the 2 lockdown periods. So the first period is looking at the number of lists, the cases, as we saw on the previous slide, that ran in the first 2 months of the initial lockdown. So this was a key lockdown period. And then we were asked to analyse, well, in the second lockdown period, in January and February 2021, what did performance look like? And this is a slightly more positive story because, as you can see, we'd managed to get to grips slightly more with infection control and the management of elective pathways. So in the first lockdown, you can see that there were 1,600 lists that ran. And in the second lockdown, we managed to increase that to 3,092. And again, you can see in terms of the throughput, in the second lockdown compared to the first, there was 139% increase in activity. So it showed that, yes, although we performed at a much lower level, and you'll see in the future graphs coming in this presentation, the NHS had learned lessons as it moved through the pandemic. So although the case throughput was low, it still increased in the second period. It went from 1.7 cases per list to 2.5. And then the additional case capacity for this data set, it had dropped. So for this particular data set on this slide, some of the lists had, on average, it was a 76% additional capacity throughput that, this is, nurses, surgeons, anaesthetists, theatre space that could have been used, but was being used very inefficiently. And it had started to improve by the second lockdown in terms of usage. What you can see here on this graph, so the top graph, the bar chart, represents the average monthly performance in the year prior to COVID. So you've got a 14-month period. March, you can see on the graph, this is when COVID starts to bite, although we hadn't gone into the full lockdown. But in the early bars, and in the yellow numbers, across the region, which, as Henry said, is 19 NHS organisations, you could see that they did, on average, about 23,000 cases per month. And that's what the yellow bars represent. And this is across 8 elective specialties. So trauma and orthopaedics, which we badge as one, although we're only looking at the elective care, gynecology, ophthalmology, urology, general surgery, ENT, and plastic surgery. And then we see lockdown hit, and you can see that average of 23,000 cases absolutely is hammered all the way down to, on average, of 3,000 cases. So a significant loss in terms of performance and the cases treated. What you then see after this 2-month lockdown period is that gradually activity starts to build back up. And you see in November, it reaches its peak prior to the second lockdown. But what's important to note is that even prior to the second lockdown, it hadn't reached its pre-pandemic averages before it dropped down again significantly. As we showed on the previous graph, it wasn't as severe in the second lockdown. We had learned so much, but you can see the levels of activity delivered was much reduced. And as Henry might pick up on later, in terms of what this has done to waiting lists in the UK, we're starting to see the actual figures come through. So throughout the pandemic, we had far fewer referrals because people weren't seeing people in primary care or coming into an acute setting for non-emergency care. So it was hard to pinpoint, what the impact on waiting list would be. But just from this, noting that the number of patients being seen reduced from an average of 23 to 3,000 cases per month. So each month you can see there was 20,000 patients that weren't treated. And then throughout the period, although we started to treat more, all of the cases that weren't being treated are obviously now being added to a UK waiting list. Just some other important notes to mention. So the percentage relates to the, as I referred to before, what's the inefficiency in terms of the lists. And for the list that ran, we were noticing that 46% of the total inefficiency is focused in 3 specialties. This was the same prior to the pandemic, and it was repeated throughout the pandemic. And those 3 specialties are the ones, of course, you would expect the highest levels of elective care and throughput. So it's orthopedics, ophthalmology, and urology. What we're starting to see is that now that we're getting some of the updated waiting list data, what we're seeing is that 85% of the waiting lists are made up of patients that seek care in these 3 specialties. So again, in terms of Poonam's point, in the the need to measure and then manage and act, it's just targeting resources in those 3 areas. And one of our initial findings in terms of, well, if we want to tackle this problem, is that certainly in orthopedics and urology, where previously ophthalmology still had a good day case usage, but in orthopedics and urology, we really need to step up the levels of day case provision of care, because that will allow us to tackle the waiting lists and increase the levels of activity and not put stress on the acute bed base, which of course will be a problem as we move out of the pandemic and into the winter period. So what we're seeing here, so we produced 3 slides. This was from a report we presented to just really give an indication of these 3 key specialties. And what you can see in orthopedics is that pretty much in the first lockdown, orthopedic activity all but ceased. So the impacts that would have on the waiting lists. So we used to see an average of around 4.3 thousand patients treated a month, and that just fell off a cliff for those 2 months. And what you can also see in the top graph are the levels of, okay, for the lists, even though, so these 2 periods relate to each other. So you can see in this, the first rectangle and then the second rectangle, even though the lists that did run, very few lists, they didn't run at capacity at all and at the same levels of inefficiency. So that was severely impacted. What you can see from the second period is that, yes, we did start to see more elective orthopedic cases treated, but again, not as many as the normal average. And as you can see from the graph, in terms of the data set, it didn't recover between the lockdown periods.
Dan, it's worth noting here, this is for orthopedics as a whole. If you go down to subspecialty, you see the same pattern, in some of them slightly exaggerated. So hip and knee, it'll probably come as no surprise, is more exaggerated than this. And if you then look at the waiting list pattern, we're just getting the data in for that waiting list. There are about 5 million people waiting for surgery in the UK right now, of which I think it's well over 700,000 have been waiting for longer than 1 year for their surgery. And so what we're just doing is correlating the waiting lists against this activity here. And you can just see those waiting lists growing. And what's interesting about them, and I think which might be pertinent to South African situation, is that while the additions to the waiting lists are growing, so the number of patients being added from outpatients are growing, equally the number of referrals coming in from primary care into a secondary care setting are growing at a much faster rate. That's what our preliminary evidence seems to be showing. And it would be interesting to know whether the audience thinks that's going to happen in South Africa. My hunch is it probably is, that there's almost this untapped account of patients waiting to be referred in. but it's what it shows is a situation of pressure point situation where demand is going to grow. There's an unprecedented amount of patients, number of patients on the waiting list, and on top of that, low productivity at this moment in time, and combine that with all the infection controls that have been put in place in theatres, that's driving down productivity as well. So, which partly explains why the need to move to something like high performance day case surgery and stuff like that. So, sorry, Dan, over to you again.
Thanks, Henry. So what we can see, so these are the three key specialties in terms of activity and performance. And what we were able to show is that, yes, the impact of COVID wasn't the same, and there was certainly a significant reduction across all specialties. But what we were able to show is that the levels of efficiency, or the impacts in terms of levels of efficiency, were varied, and also in terms of the actual activity drop-off. So you can see in ophthalmology, we still retained about 14% of the activity, and the inefficiency on the list that did remain, although it peaked at 70%, they were able to get back to a level of efficiency prior to the second lockdown that was similar to the pre-pandemic levels. And you can see in the second lockdown period, they were able to cope much better. And in terms of urology, again, the activity did drop off, but we still retained about 20% in terms of the levels of activity. But as you see here from the first spike, the inefficiency on the lists, was much greater than ophthalmology. And again, it peaked, or it started to move up again in the second second lockdown period. But they were able to tackle it. So this is evidence of certainly learned lessons. And we'll just talk about some of those keynotes at the end of the presentation. So in terms of inefficiency, and when we look at that, or the levels of efficiency on lists, what we're looking at in the data sets is if there's a planned period of time that you target to use your theatres, and in the UK, it's roughly split between half-day sessions, which is 4 hours of operating time, and all-day sessions, which is usually 8 hours of operating time. And what we at Four Eyes are able to show using the data points in terms of the planned start time, well, what's wasted? What time is not spent with a patient, either in the anaesthetic room, actually on the table in surgery, or just as they're getting ready to move into recovery. And that's what these bar charts represent, that for an average list, what time is wasted. So this is the time that's not spent with a patient. And as you can see, even prior to the pandemic, there was, of all of the lists in this region, on average, they started 25 minutes late. So that's a pre-pandemic level of inefficiency across all of the theatre lists in the 8 key elective surgery specialties. And then at the start of the pandemic and the first lockdown, this jumped up significantly and then started to come down. But what we see in terms of late starts again is that by the time of the second lockdown, they had started to get to grips. And even though we were in a second lockdown, it was closer to the average in the first in terms of late starts in the sessions. The blue bar chart represents the intercase downtime. So that's the time between patients. And that's when there's no patient in the operating theatre, and we can see, but one is due. And we can see that on average, it's 25 minutes per list, so hangs around that sort of level. And then during the pandemic, obviously, the first lockdown, it goes up. And we can see there's a peak of 51 minutes in July. And what we've noted is that, of course, the added pressures of additional cleaning and additional elective control was increasing the average time between seeing patients in the operating theatre. The grey bar represents the average early finishes. So although the list was schedules to finish at a certain time. This is the time where the list finishes early. And it was around 12 to 13 minutes prior to the pandemic. And then, as we showed before, it jumped right up. So lists were finishing, around about nearly an hour early. And then slowly it dropped down. But even in the second lockdown, lists were still finishing half an hour early. And that's a factor of, late cancellations, where patients were not so keen coming into hospitals during the COVID period. So on-the-day cancellations certainly increased. And just generally a smaller patient pool that was available to treat in terms of pre-op patients and patients that met the correct criteria. So we just weren't able to fill the lists. What you can see in the yellow and blue bars, the yellow represents the number of overrunning lists. And that was the average that hung around 2,000 sessions per month list that overran. But the blue bar for each month, we set the blue bar against that and say, well, okay, these lists did overrun, but the blue indicates that if they hadn't started late, then it's the number of lists that actually would have the net levels of overrun that we would have experienced.
It's worth noting on that. So a lot of the, actually, sorry, Dan, if you go on to the next slide, a lot of these things that we're highlighting here, it come down to procedural length. And so how long does it take for individual surgeons to carry out certain procedures? And what's interesting about the findings is that, well, we're not showing the data up here. It comes no surprise, there's huge variation between individual surgeons. You have surgeons who can do procedures quickly and other ones who take slightly longer. There is that natural variation. What we're noticing is, just from some of the data we're collecting started to collect from the US, quite significant variations between regions, hospital groups, and so on like that. That drives a lot of the opportunity on theatres and the ability to recover from sort of this COVID pandemic. And it'll affect a lot of these things that Dan's about to cover or talk about right now, in terms of the things that have been affecting the number of patients on theatre lists. Dan.
Thanks, Henry. So in terms of Four Eyes, we are a software and analytics company, but we're also made up of teams of consultant clinicians, former nurses, theatre nurses, accountants, data scientists, and we do actually go in on the ground into trusts and use the data to highlight areas of improvement and actually help trusts work on these areas that have required improvement to increase the throughput of elective care. Now, what these boxes represent are some of the key themes that we've seen throughout the pandemic. But what's really interesting is that, as I showed on the previous graphs, there was already a level of inefficiency on the lists, and all of these issues here are things that we saw prior to the pandemic. Issues that were affecting levels of throughput in theatre activity, built-in inefficiency that had been built in over a period of years. And what we have seen is that the pandemic exacerbated these issues. It caused lots of new issues, but in terms of these issues, what it did was exacerbate problems that were already there. So, for instance, the late starts that you can see, that became a significant problem, but it was already an existing problem. Lists already started late. And that's, a function of different staffing groups not being on the same timetable. So consultant sessions not starting or consultant surgeon sessions not starting at the same time as anaesthetists and theatre staffing groups in terms of the nurses and the operating clinicians. Just a classic example. Or late starts being caused by not having the equipment ready, the patient not being there. But of course, with COVID, this certainly exacerbated it. Something else that we saw prior to this, but certainly during COVID, this was severely impacted, is the levels of preoperative assessment capacity. So this was greatly reduced throughout the pandemic, which meant the levels of patients that could be seen also dropped off. And what's absolutely important is that in terms of, we know that there's a massive and growing waiting list of patients, but we have identified the pre-op assessment capacity as a significant limiting factor, holding back the throughput in theatres. Inefficient list booking processes is something that we see time and time again. So devolved, even within the same organisations, different, the way that patients are booked onto lists is not the same across the organisation. It's not the same between the different specialties. Actually, something that we find is different consultants book their lists differently. They don't refer to accurate and historic data. They don't look at performance. They're just using often, average times that, it's an average that might relate to many years previous. It doesn't look at the most recent performance data. Something we also see is that there's not a consistent duration of lists. So again, between different specialties, there's no set times. It becomes an issue when you're sort of scheduling patients also, that it fluctuates and there's no consistency. You can see in the bottom left-hand corner, the on-the-day cancellations. That's also a function of levels of pre-op capacity, because patients, they get to their date of surgery, but they haven't been pre-oped. Obviously, through the pandemic, there was a wariness of patients to come in. So on dates that had previously been agreed, the patient on the day, certainly throughout the pandemic, we saw levels of patient-initiated cancellations increase. But also in terms of infection control, etc., or the number of beds available in hospitals for post-operative care, led to another increase in terms of on-the-day cancellations. Henry touched upon it before, and we looked at it in the slides. There's, in terms of holding back throughput, there's patients that could have been treated in a day case surgery setting, but there hasn't been the transfer in terms of the pathways or the number of day case surgeries available to complete the care. And in future, to really maximize throughput, we need to increase the day case capacity right across the UK, but certainly in this region. Something I noted before, it's linked to the inconsistent list duration. You might have inconsistent levels, but when it's pointed out that capacity could be maximized if diaries were coordinated a little bit better, or theatre times changed, the use of theatres on the weekends, 7-day work-ins, 7-day working practices, potential for surgery to take place in the evenings. Lots of organisations, they often resist some of the recommendations, and that's leading to a drop in capacity. This one, again, the final point is just the levels of capacity available in terms of theatre space and not matching up to the diarised job plans of the surgeons. And so the theatre space might be available, but it might not be enough to meet the required, or what the organisation is paying for in terms of surgical time from a consultant. Or conversely, it might be that there's lots of time available and there's an excess of time, but the way the consultant diaries have been worked, they just haven't given enough time to surgery. So again, all of these problems existed before the pandemic, but certainly we've seen they have been exacerbated throughout it and need to be tackled to deliver the levels of efficiency that will be required in the future, and the levels of throughput required to tackle the massive waiting lists that we now have in the UK. And just to finish, if there's, if your organization, if you would like us to process your data, and we can produce a dashboard and levels of insight that would be available to you similar to that we're running in the UK, then please feel free to contact myself, Gazelda, or Henry.
Thanks, Dan and Henry. Thanks very much for that. Very interesting. There's a few questions for you, but maybe we'll first start with a question on Poonam's presentation. There was a question around reinsurance. Christoph, do you maybe just want to talk to that a bit? Poonam did also type in an answer, but maybe Christoph can also add some commentary there.
Sure, thanks. It's an interesting question, and perhaps it relates to the, let's say, the extinction of reinsurance in South Africa. Since, about 20 years ago, it has been arguably a little bit abused by some players in the market, and the regulator has taken quite a dim view on reinsurance since, but that's a long time ago. From an actuarial perspective, it's very hard to distinguish today. If you transfer risk to a reinsurer, or if you transfer risk to a managed care organization, or to a doctor through a provider through capitation, what's the difference between those? And from a regulatory perspective, they treat it very differently. I think in the interest of simplicity, I'd say the regulatory definition now basically implies that the person receiving the risk determines what kind of arrangement it is. So if you transfer to reinsurance, you're going to call it reinsurance. If you transfer to a managed care organization, you'll call it managed care or risk transfer. If you transfer to a provider, you'll call it capitation or ARM. Even though from an actuarial perspective, all of these transfers are really very similar. So in section 20, subsection 3 of the Medical Schemes Act requires all reinsurers' contracts to be approved by the regulator. Unfortunately, the regulator takes a fairly simplistic view as to what a contract in the best interest of members would be. But I am hopeful that this is perhaps something we can resurrect with the regulator. So the institutional memory within the Council of Medical Schemes of the abuse of reinsurance is all but gone. And I'd be quite keen to encourage, reinsurers who are interested in entering into the space to perhaps reopen that dialogue with the regulator and go with an application, under section 20 of the Act, and see whether we can resurrect any of that. I think the time is right to try some reinsurance again in South Africa. Thanks for the question.
Okay, thanks. Henry, I think you've started to answer some of the questions. There was a question about, infection control and the timing of that, whether that's impacted the capacity of being able to do cases. And I think you mentioned there in the chat that that's included in your measurement. So even over and above that infection control, there's still capacity to do more elective cases. One of the questions was also around how long you think it's going to take to clear up the backlog treatments or elective procedures, how that could impact the NHS budget. And maybe we can link that to Victoria's question, where she's asking, sadly, there are also some people who have passed away who might have been needing elective care. So will that also have an impact on how long it will take to recover all of the elective care?
Okay. A lot of questions there, so I'm happy. I will answer all the questions. So if I don't answer them now, I will come back and answer them as well. That last point, yes, look, we all know that patients don't fare well if they stay on a waiting list for a long time, and so I don't have the data immediately to hand in terms of how many patients have died and come off the waiting list. But put it this way, it's not been enough to affect the size of the waiting list. It's still growing in size enormously. The only way that's going to be affected is by either clinicians choosing to take patients off the waiting list, making a clinical judgment and taking them off, or providing them with the surgical treatment they require, and so that's seeing them through. Are you aware of the potential? Okay. Sorry, I'm just looking at the question. Are you aware of the percentage of cases that were cancelled due to positive COVID tests? Again, I can get you that data. And what we've noticed is that on the day cancellations, so patients turning up and being cancelled as a result of that, has gone up quite significantly. Equally, that and that's partly as a result of the preoperative assessment not being able to run as efficiently or effectively as it was doing pre-COVID. And that's always been a major bottleneck actually in the UK healthcare system. The preoperative assessment, its capacity and its ability to get patients ready for theatre. That's one of the major constraints in driving productivity through theatres. And all we've seen is that COVID has exacerbated that enormously and resulted in greater on-the-day cancellation rates. So I hope that answers that. How did this impact on the level of elective cases? It drove it down. It did drive it down.
Henry, can I just come in there? So it's a really good question. Something that we absolutely note as a company is that in terms of cancellation data, as a data set across the NHS, this is one of the poorest data sets in terms of levels of objectivity, reliability, different methods of collecting between different organizations, even though they exist in the same governance structure. Cancellation data is less reliable in terms of a data point when compared to other sources of the data that we do collect. Would that be fair to say, Henry?
Yeah, I think so, definitely. I'm just trying to remember the other questions you were asking.
There's a really interesting point on that's been made about orthopedic care and how quickly it recovered. And that's, when compared to the region that we were looking at, you saw that it took a long time to recover, never actually got back. But in South Africa, it said that they were able to get back very quickly, which is really interesting.
I see we also have a raised hand from Guni. Guni, I'm not sure if you want to ask your question live, and then I'm going to hand over back to Barry to just end us off, because we are actually getting to our time limit now of 10 o'clock, so we might have some people dropping off. But I'm going to see if Guni wants to ask his question live, or maybe Guni just had a hand raised by mistake. Then I'm going to hand over to Barry to end us off and just summarize today.
Thanks, Griselda. Thank you to our panelists, especially our colleagues from the UK for joining today, just to share some novel analysis that's going on in other parts of the world. So thank you for sharing. Thank you to everybody for joining today as a participant, and also to our panelists who managed to squeeze in all of this remarkably impressive preparation, even though times are very busy. I just wanted to close with a couple of key themes which are very close to Insight's heart, and that is the use of data to make better decisions. And we can see from the talks today that this is applicable not only to corporates and organizations, groups, for example, in the consideration of alternative reimbursement models, but also to individuals, as Gary was showing us, that we think that personalized data around an individual, to take into account your own idiosyncrasies and individual characteristics, will also lead to better decision making at that level. And we're certainly keeping our eye on the technology in that space. We're hoping that both the hardware and the software will improve to make it much more accessible and ubiquitous way of refining individual behaviors. On the alternative reimbursement area, we think that South Africa's been dragging its feet there for way too long, and are very excited that there's some renewed interest there, and we'd be happy to talk to you about that if you want to sort of even have a brainstorming session and see what's possible. Even for things like I see Brian posed a question about that you need a balance sheet for that, even for brainstorming novel solutions to those sorts of problems. Sometimes individual providers, small pharmacies or individual doctors might think they can't take risk, or they have a poor understanding of what that risk means. But there are some novel solutions to that, working in cooperations or broader looser groups, virtual teams, those kind of things. Anyway, without going into detail, lots of options for moving forward and doing interesting and innovative work in that space. And of course, we like to support all of that work with data and analysis. So thank you all very much for making the time early on a Monday morning. We wish you to stay safe in this lockdown level 4, and hope that you'll join us for the next Foresight session coming soon. Keep a watch out for it. Have a great day. Bye.